Kirk, I already made you co-host, so I think that you are good to go.
I will share my screen. Let's see if I can share the right one.
And I have it too, just in case you need.
Can everyone see my screen?
Yes.
I was asked to speak about coordination and transition of care. This is kind of an interesting topic. I'll be a little bit briefer than usual, I think, because I think in some ways it's simple, but in some ways it's very complicated. Oops. First, I'm going to sort of talk about philosophy and practical issues. And, you know, it's kind of interesting when people talk about who they should refer and whether you should see a patient or not. My personal philosophy is that when I'm asked to see a patient, I don't care what they have, I agree to see them. And some people sort of try to figure out how to put off patients. I don't do that ever. Part of the reason is that, when I was in training, I learned that when I was asked to do a consult, oftentimes the story that I got about the patient that I was asked to see had little bearing to what I actually saw. And so I can't say that I shouldn't ever see a patient until I sort of know in more details. And so I'm usually always willing to see a patient. And I think that's sort of our philosophy here in the memory multidisciplinary memory clinic at WV. We see patients. I oftentimes see patients that are quite interesting and quite atypical for the typical patients seen in a multidisciplinary behavioral neurology specialty clinic. The other thing I want to mention is that there's a shortage of behavioral neurology specialty care in general. And that means that if we were to see all the patients that that have Alzheimer's disease or similar disorders or the atypical dementias, we would rapidly be filled up and we would not be able to see the complex patients that people need us to see. And so part of our mission has to be to help primary care be able to manage more common issues related to memory disorders. One of the last things I want to mention is that there's always a trade-off between hubris and confidence when it comes to clinical care. It's very easy to believe you can take care of everything, like I mentioned above. Even though I said I'm always willing to see patients, maybe it's because I have imposter syndrome. I'm always willing to ask for help. And some people may be less willing to ask for help even when they need it. But I think that balance of knowing when you're over your head versus taking care of patients is an important thing that we all have to struggle with. So, the simple question of when to consult with a specialist for memory problems. And I think, it boils down to two things: atypical cases. There are many rare causes of memory problems, and it's important for patients to get a diagnosis with confidence. And because the average primary care doctor is not going to see the atypical cases, I think at least most patients that have atypical cases should be seen at least one time by a specialist so that we can be confident that they're getting the best care they can get. The other reason is for the need for services of a specialty service. The atypical cases, there are a number of ones that I want to mention in particular. Early onset dementia is something that should be seen at a specialty facility. There are oftentimes, specific reasons. Oftentimes, early onset dementia can be hereditary. It can be due to a paraneoplastic disease and possible prion diseases, all of which require specialty care. There are also patients that represent a diagnostic challenge, and many neurologists are capable of managing these things, but we oftentimes offer a second opinion. Examples are that, we see patients where the question is whether someone has the dysexecutive form of Alzheimer's disease versus behavioral variant of frontotemporal dementia. And those are actually difficult to distinguish. And quite frankly, it often requires special studies to make the distinction. Most primary care people don't see enough patients with aphasia with dementia to feel confident in their diagnosis. There are three common causes: the logopenic version, the non-fluid agrammatical and semantic dementia. And although I think families feel happy to have seen an expert that can tell them with confidence they've seen cases like this, in some ways it is not as critical that they see a specialist, because in fact we don't have very much to offer these patients at the present time. Most of these patients actually would benefit more from seeing a specialist with speech disorders and speech therapy. And that oftentimes is only available at a tertiary care facility. The other major reason for seeing a specialist is patients that have extrapyramidal symptoms. Some of my lists got cut off, but the distinction between Alzheimer's disease with Parkinsonian symptoms versus Parkinson's disease with dementia versus dementia with Lewy body, cortical basal degeneration, and primary progressive aphasia are all diagnoses that we regularly make in specialty clinics. And the difference between good care and great care in these things is clearly, there's a distinction. So I think patients that fall into this category should always be seen at least once by a specialist. There are, looks like I had a duplicate slide. There are also challenging medical management problems. The common problems that get patients referred to us are when patients have hallucinations, paranoia, agitation, and depression and anxiety. All these problems can be helped by good quality care. Most of these problems actually involve a combination of teaching patients, families how to cope with the problems, as well as pharmacology. So, going on to offer what a multidisciplinary clinic can offer is probably one of the more important things is a diagnosis. Families oftentimes go on a diagnostic odyssey, particularly for atypical dementias. And seeing someone that says, "I've seen many cases like this before," makes them feel less confident that they have to keep on, makes them feel confident they don't have to keep on looking and that something is being missed. We oftentimes see patients for a second opinion by the neurologist in the state. Another thing that we offer is FDG and amyloid PET imaging, which isn't available at most community hospitals in the state. We also provide the opportunity for patients to participate in research. The reasons why patients and their families want to participate in research is quite varied. Sometimes it's simply altruistic. Other times they're hoping to get access to new therapeutic modalities that are still in development. And oftentimes they would like to know that they're getting access to or have the opportunity to get access to the latest and greatest. Um, One of the major roles in our multidisciplinary clinic here at WVU is that we offer patients and their family education and services to help them cope and manage with the disease that they're confronted with. Um, I can tell you personally that, the average patient I see in my um, neurology clinic, new patient, I spend an average of 90 minutes per new patient. And that's a rather rare thing for patients to receive that much um, one-on-one time with a physician that helps educate them and provides them with a thorough evaluation to know that, that they're being listened to and that they, can feel confident that no stone was left unturned. One of the reasons that I think is particularly poignant in this era is specialty treatment, and aducanumab or aduham is something that everyone in the Alzheimer's Association is acutely aware, and is something that we are offering here at WVU, and it's something that probably should be reserved for specialty clinics. I'm going to talk a little bit more about our workflow um, for selecting for patients for aducanumab. So for those of you who are not aware, aducanumab is a biologic that has been conclusively shown to remove the plaques, the amyloid plaques from patients with Alzheimer's disease. It's been controversial over the years whether, in fact, this would help people. When I was in training years ago, the first mutations were found for hereditary Alzheimer's disease, and the first one was in the APP gene, which is codes for the amyloid seen in Alzheimer's disease. And it led to the amyloid hypothesis because all patients with these mutations always got Alzheimer's disease, and it was often early onset. And this led to the idea that if we could get rid of the amyloid, that would make a big difference in the course of people's diseases. We now know much more about the natural history of the development of amyloid plaques and tau tangles in Alzheimer's disease. And some of my own work has added something to this story. Patients with the APP mutations and the presenilin 1 and 2 mutations, all of which are involved in amyloid, always lead to Alzheimer's disease with tangles. But the development of clinical symptoms in Alzheimer's disease is more closely tied with tangles. Before the identification of mutations, there was common discussion of whether what was the most important feature in the biochemistry laboratories. There were laboratories that studied principally tau, which codes for the neurofibrillary tangles, and those focused on amyloid. And with the identification of mutations in A-beta, most of the people that focused on tau stopped focusing on it anymore. My own work, though, was to identify hereditary dementias with neurofibrillary tangles that did not have plaques. And most of these patients had frontotemporal dementia, the behavioral variant of frontotemporal dementia. But this sort of reopened the argument about whether the plaques were most important, the tangles were most important, because patients with mutations in the tau gene always had developed dementia, and yet they never had plaques. And this led to a renaissance of the study of the tau gene. And because the development of tangles is more correlated with disease, it can be easily argued based on a somewhat genetic argument that we should have been focusing on tangles all this time. So, there are And we now know that the tangles can spread from cell to cell in Alzheimer's disease like a prion. And this suggests that if people are symptomatic, meaning they already have tangles, that it may be too late to be giving treatment to remove the plaques because the tangles will continue to spread. At least that's one argument. And so, because of the controversy about whether aducanumab actually makes people better in this argument, there are naysayers that say that we shouldn't be doing it. Even though I've contributed to the argument that says that maybe it's not a great idea, I approve of giving this medicine, and we're giving it here in WVU. We've started giving it, and I'm going to talk now about the selection criteria that we use this. The data that's available suggests that aducanumab is only useful probably in patients that have very early disease. And I would argue that may mean that removing the A beta may reduce the number of new foci for the tangles, which would potentially slow the course of the disease. And so on that vein, I think I'm willing to give it, particularly if people understand the risks involved. And so we're offering it to patients that have MCI or very early other disease with no other explanation. We go through a consensus diagnosis after neuroimaging and imaging, there's some typos there, imaging and neuropsychiatric evaluation. And so, it's pretty easy for most clinicians to want to help everyone and try to do things, even if they're likely to be hopeless, to give patients hope. And so we use a consensus diagnosis to try to assure that we're giving this treatment to the patients that are most likely to benefit. Part of our concern is that it's an expensive medicine currently. I think it shouldn't be as expensive, but I have little control over that. And so given the costs and the cost to the public, we think it should be reserved for patients that are most likely to benefit. Our general criterion is that we think that people should have a mini mental status of 21 to 23 or greater, have a CDR less than 0.05, have some evidence of cognitive impairment and function, and that this means having an FAQ between 5 and 12. And we require them to be amyloid positive. The amyloid positive in most instances is established doing a lumbar puncture and looking for the ratio of phospho-tau and A beta 1 to 42. And this strategy, we think, is going to identify the patients that are most likely to benefit. We also rule out patients. I'm sorry, this is our typical workload. Subjects, have to have cognitive impairment. They've done these things. The MRI, we look for medial temporal and parietal lobe atrophy, but don't always find it. But if they have neuropsych consistent, we go on to do an FDG PET to look for the pattern consistent with AD, and they have to have no evidence of significant cerebral hemorrhages. And then we do a consensus diagnosis, and then we do the amyloid positive, look for amyloid positivity with an LP or PET scan. And we think this strategy will identify the patients that are most likely to get it. We're still going through the process of trying to get insurance approval for many of our patients, and this is going to be an issue. It's been said that if all the patients that might benefit got this medicine, the cost to the government would be more than the defense budget, which is pretty spooky. And it's going to be a while before it's sorted out who we give this to and who we don't. And so in summary, we think, the times to refer patients to specialty clinic is when there's diagnostic challenges, when there's specialty services that are required. Probably equally as important, though, is how we can help patients that get the best care from primary caregivers. And one of the things I've learned over the years is when I see patients that I feel that I'm out of my depth with, I always follow up with seeing how the primary caregivers deal with that and learn from them how to do it. So the next time I confronted with a patient like this, that I can make suggestions of what's the primary care, and also feel free to consult them again to see if there's anything new that comes up. And so this balance between referring patients to a specialty clinic and caring for them in the primary care setting is going to be an ongoing thing. And there is no choice but that to get the best care for our patients, primary care is going to have to step up some. And we're here to help do that also. And with that, I'm going to stop.
Thank you so much, Dr. Williamson. That was a wonderful presentation. And it's nice to hear that you do spend so much time with your patients, the 90-minute initial time, because I do think that going to a specialist, it's really important. And even with I really love my NP because she does take time. I can't thank them enough for taking the time to hear all my, concerns and needing all the answers I need. So we thank you for that.
I would like to be seen by someone that spends the time, and unfortunately the bean counters are having too much of an effect on us.
Hard. Yes. Does anybody have any comments or questions that they would like to make?
I just have a question. Dr. Wilhelmsman, did you say that you all have administered the aducanumab already?
Yes.
Okay.
I think we're the first place in Pennsylvania and West Virginia that has.
Okay, that's exciting. I didn't realize that. I've been working with the aducanumab, the reps down our way. I think they're different for Morgantown, but they're close. But they haven't actually administered the first dose around here.
Well, I think. I think there's a temptation, as I said, for lots of people to give this to anyone with Alzheimer's disease, as was the first initial indication. Mm-hmm. And I think that's a mistake. I think, the more severely people are affected, the more likely they are to get hurt by the medicine. Right. And so I think we have to be judicious.
Sure.
And, we didn't have to get insurance approval for the first patient because of their personal circumstances. And so that was what made it easy. But I'm sure for our, we're working through the insurance for our other patients.
Sure. Thank you.
Anybody else have any comments or questions that they would like to make?
I want to see the dog. We don't
Whose
get to
dog?
see people's pets.
Oh, you can see my pet. I don't mind showing her. We'll do it after we stop recording, though. We can wait to the end when we do the poll. I'll let her come in here. She's crazy though. She's wild. I'll take the computer, but she's cute. Her name's Evie, and she's a husky. Amy?
I'll ask a question.
Yay!
But I'm also willing to show my pet as well. So thank you, Dr. Williamson, on the information on the tau tangles. This is the first time I've heard so much about this, especially as it intersects with Aduhelm and all of that. So that was really helpful to hear. My question is, so after you receive a referral from primary care for a consult how then are you communicating back to primary care? Because, you know, this patient isn't going to necessarily be yours forever. You want to get them back into the care of the primary care provider. And then I'm guessing that we're also hoping that they're providing care based on this care plan that you're developing for the patient as well. So how is that communicated back?
So we send extensive clinic notes to primary care people that refer people to us. I think we're not doing as good a job yet as we need to transition care back to patients, in part because our program is relatively new. And I think, you know, there isn't enough dementia care in the state. And so eventually we will get swamped. We aren't yet swamped, and so we haven't pushed it as hard as we need to. One of the ways that we're trying to, you know, to push off the time when we get swamped is to hire nurse practitioners to do the follow-up care. But I think that in the long run, we need to spend more time teaching primary care how to manage the garden variety cases of Alzheimer's disease. And there actually is quite a bit of an art to it. And, you know, we spend an awful lot of time teaching patients and their families how to cope and how to get the best quality of life they can. And that's beyond the scope of what most people can do in primary care, given the sort of 15 minutes per patient most people in primary care are allowed. And so we're going to have to do better at doing that. And we currently, you know, as I say, haven't been forced to do that. I've only been in West Virginia since the end of November of last year. And in North Carolina, where I came from, we had an extensive outreach program to help primary care triage the patients that needed to come to us by giving them instruments that they could administer through their support groups as opposed to them primarily, and then giving them care plans of how to take care of the typical patient that doesn't need to be seen at a specialty clinic. And so right now, our patients that come to see us unfortunately like us too much. And so they want to typically stay with us. And as a consequence, you know, we're sort of letting that happen, but in the long run, it can't, because there just isn't enough, you know, behavioral neurology care in the state. So, but I think, you know, I think in the process of trying to build the program here at WVU, we've been focusing on mostly giving very, very high quality care until we get swamped. And then by out of necessity, we'll have to go on to plan B. But, you know, the notes that we provide actually give a hint about how we take care of our typical patient when we, you know, I mean, what do we typically do when, you know, someone has Alzheimer's disease and has behavioral disturbances? You know, the type of behavioral disturbances we, you know, there's a group of us here at WV that care for those patients, and we all do it a little bit differently, but there is some common themes. And by reading our notes that go back to primary care, that they can get an idea of what we think is an appropriate strategy. But we would have to do better.
Well, and I think that this platform, you guys have done a fantastic job getting the information out. So I think the more primary care providers that participate in the ECHO, the better. But I think this has been a really good platform in getting great information out there.
Thank you 100%. Very informative. Thank you so much. Does anybody else have any comments or questions before I make the announcement, do the poll, and show the dog? Go ahead, Teresa.
I had to get myself off of mute. So I had a call with Bernie Schewers, which I believe works in your all's Schrewers, maybe in your all's area. And he actually did some research, or they did like a poll with PCPs, yeah, in West Virginia. And so, a lot of the answers were kind of, I think, what we knew, like these doctors just don't know enough about screening tools. They don't feel like that they are educated enough or prepared enough to deal with some of the screening. So he's working on finding a way to share that information with us in terms of what particular practices responded. And then I'm hoping to be able to grab Amy a little bit and be able to maybe reach out to some of those PCPs and try to even give them some tools on, what testing and I had mentioned that maybe we could even work a little bit with the echo program, on maybe even doing an echo just on that, like what mini cogs screeners are out there, what should these docs be doing. I don't know, but I think it would be a good start, at least to grab
I
some
think
of
so.
those
I
folks.
mean, many primary care patients that come to us have had a simple instrument, and that actually isn't quite enough to decide who needs to be referred or not. It's good enough to make a decision on whether they have some cognitive impairment,
Mm-hmm.
but there are instruments we are working on in North Carolina, and we were partnering with primary care where we could help them screen and collect the screening information and then help give them a plan to take care of their patients in situ as
Sure.
opposed to coming to us. When,
Sure.
and so, you know, the typical patient with Alzheimer's disease, without behavioral disturbance, doesn't need to be seen in a primary care. But most primary care physicians actually, more than half of them aren't giving the two available medicines that help improve outcomes. I mean, most
Right.
people in primary care don't like using the cholinesterase inhibitors because they get phone calls.
Mm-hmm.
People don't tolerate it. But in fact, the cholinesterase inhibitors and Namenda, the glutamate antagonists, those patients are less likely to end up in nursing homes and stay home longer. And so, it's sort of, that should be a goal for everyone. But, the reality of primary care is there's limited time, and figuring out strategies to cope and be able to deal expeditious with patients is a problem because of compensation strategies. And so we were also working on strategies where we would provide consultations to patients and figure out how they could get paid to do the screening and do the primary care work in the framework of which they could actually see patients. And that's
I
now,
believe, and we may have talked about this before, at their annual well visit, Medicare will actually pay for a mini, cognitive assessment, but I'm not even for sure that a lot of our physicians are aware of that.
yeah, I see a lot of patients do this, and then the default answer from my perspective is they get referred to us,
Mm-hmm.
as opposed to having a plan for how to take it and actually deciding whether they need to send them to us.
Mm-hmm.
And I can certainly see someone in primary care wanting to get them off the patient off their plate
Mm-hmm.
because of the time that it takes to care for families and the patients with Alzheimer's disease. And so,
Sure.
between doing the things the Alzheimer's Association does by, forming support groups and teaching patients, we can do better than that. But if we had to rely on primary care doing that education, not so much. It's not going to
Right.
happen because they can't, because the reimbursement, they can't afford to do that. and they wouldn't be able to care of their patient load. And so figuring out a way to efficiently do that and get people that actually need to see specialty clinics is, going to be the task over the next, 5 years, I think.
I think you're right.
I have a question.
Sure.
When do you recommend starting Aricept, and then from there on adding on Namenda in terms of and
I can tell you the party line. Yeah, I can tell you the party line and then tell you what I do. Okay. So the party line is, to have made the diagnosis of early dementia for cholinesterase inhibitors. I find that many patients that have even subjective cognitive complaints benefit from cholinesterase inhibitors. And so I'm inclined to use it very early because I find there's little cost of doing that. I usually tell my patients that it's a little bit like learning to smoke because the acetylcholine that's increased by the cholinesterase inhibitors, principally in the brain, stimulates the nicotinic cholinesterase inhibitors, and it sort of explains the side effects. But I also explain that, if you talk to a college kid and they're a smoker, they start smoking a lot more during final exam period when they're trying to concentrate and study when they're tired. And, we all have this image of, professor sitting in his office in the late night hours trying to study and concentrate, smoking away at a cigarette. And the reason why they do that is because they can concentrate and focus. And so, I sometimes tell the story of my dad. I told him about nicotine and its relation to that when he was in his late 70s. And my dad was a scientist and couldn't focus on his experiments in his laboratory as well anymore. And so my dad started freebasing nicotine at age 78. And he found it worked great. He eventually developed dementia. I don't really recommend freebasing nicotine because it's kind of a toxic and dangerous thing. But he found it worked really well for him. And that's not an uncommon experience. And even in the patients that don't notice a difference, if you look on an epidemiologic basis, the patients that use cholinesterase inhibitors are less likely to end up in nursing homes. And that's because it actually probably has a bigger effect on behavior than it does on memory. And, if you look at the reasons why people end up in nursing home, it's the items on the neuropsychiatric inventory: paranoia, psychosis, hallucinations, and things like that. And they're less likely if they are on a cholinesterase inhibitor. The other thing that I usually prescribe it in the evening, but, there are occasional patients that we see that it causes nightmares and vivid hallucinations. That's pretty typical in patients that have, incipient Lewy body dementia or have more posterior predominant Alzheimer's disease. And so they have to take it in the morning. So you have to educate them well, and you have to educate them that they're going to feel crappy. But like smoking, if you stick with it, you'll be able to take it. And so, but there are a few patients that never can. When it comes to memantine, the dictum really is that's moderate Alzheimer's disease. I tend to give it earlier when after people clearly have some evidence of Alzheimer's disease. I give it for the same reason. If you give patients memantine, they are less likely to end up in nursing homes on a population basis. And so I tend to give them early. But that isn't, medicine is an art, and we tend to do what we learn to do over time. And so I tend to be an early advocate compared to most of my peers.
Thank you.
No problem.
Thank you, everyone, for such wonderful questions. We still have time if you have any more comments or questions. Okay. Well, our next session will be on October 5th, and it'll be all focused on the new Alzheimer's disease medicine. So it'll be somewhat of an open forum, but it'll be really great discussion, I feel, to be
I'm
part of.
sorry
Yes.
for covering so much of it today.
So we covered a lot, but I think it'll be really interesting.
There's a lot more details to discuss.
Yeah, so I think it'll be really interesting, and we hope that you all can make it and bring your questions or anything that you have on your mind to that session. I will go ahead and